Because the scaphoid is difficult to image because of its angulation to both the central ray and to the image receptor, we've got some specialty views of the ulnar. Going back to Merrill's, Merrill's identifies a Stetcher method, and it also identifies ulnar deviation. But at a lot of hospitals, as a matter of fact, every hospital I've ever worked in, that they had specialty views of the scaphoid and the navicular, they combine both the Stetcher method with the ulnar deviation. So the Stetcher method utilizes a 15-degree cephalic angulation, or a angulation of the anatomy that would require the elevation of the wrist at a 15-degree angle with a perpendicular central ray. And what that does is that it puts the central ray more perpendicular to the distal portion of the scaphoid. So that does a lot to limit the foreshortening of the distal portion of the scaphoid, but it doesn't do a whole lot to desuperimpose. So the ulnar deviation desuperimposes, and that angulation puts the central ray more perpendicular to that distal portion of the scaphoid. So most of the hospitals that I actually worked in, if they had a specialty view of the scaphoid, it was this navicular view that incorporated both of those things. So ulnar deviation with a 15-degree cephalic angulation. But just remember, for testing purposes, especially when you get to the registry, the Stetcher is just that either elevation of the hand so that the wrist is at a 15-degree angulation, or a 15-degree cephalic angulation of the central ray. So again, we got scaphoid fat pad. You got three different areas that in the scaphoid that could take some sort of fracture. You got the proximal portion, you got the distal portion, and then right across the middle, where it goes from pretty much parallel with the forearm to this downward trajectory, is what we call the waist portion. So different angulations for each one of those. 5 degrees on the proximal end, so it's pretty parallel. Distal ends at a pretty steep angulation. So the purpose for the Stetcher is to kind of split the difference between them and maybe put it parallel to a fracture that would be in the waist portion. So one thing that I've seen in the scaphoid and the collimation beam restriction for a scaphoid or a navicular view is that the technologist or student wants to include an area similar to what you would see in a wrist, and there's just absolutely no reason for that. The only bone that you're looking for is that bone right there. So you can collimate down to a very small area, just to improve the appearance of the bone that you're interested in seeing. So again, 15-degree cephalic angulation, or elevate the hand so that it's at an angulation about 15 degrees. Ulnar flex it, that desuperimposes, plus it puts the central ray more parallel to most of the scaphoid itself, and it collimate down, and you can get a very nice image. So the forearm is probably the last thing I'm going to upload today. The forearm, we talked a little bit about differences in thickness between the proximal end and the distal end of the forearm, and how to compensate for that for the wrist. Problem is, for the wrist and the elbow, you can use the position of the anatomy on the image receptor in order to compensate for it. But whenever you're looking at the forearm itself, you can't really do that. So on the forearm, the AP and the lateral are going to be the same technique. Your image receptor size is going to be 14 by 17. If you happen to be doing you happen to be working somewhere that you're using CR systems instead of DR, you can put 2 on 1. Just consider which image to shoot first, or which projection to shoot first. And the reason I say that is because I've seen students and technologists make this particular mistake. They shoot the AP here, all right, and then they want to put the lateral on the opposite side, but they've used a 14 by 17 image receptor, and maybe the patient can't reach all the way across to the opposite side. So what they'll do is they'll shoot the AP with their hand down this way, and they'll say, okay, patient can't reach across, so I'm just going to turn the image receptor around and shoot the lateral, so that on the AP, the hand is at this end of the image receptor, lateral, it's at that end of the image receptor. And nothing will drive your radiologist quite as crazy as having to do the mental gymnastics of turning the image around in his head. It's really kind of a petty thing, but you don't want to be chewed out for something really kind of petty. So consider which one that you're going to shoot first, and make sure that the hands are at the same end of the image receptor. Consider the divergence of the central ray. Your image receptor needs to be not just as long as the anatomy, but it needs to be about 1 inch to 1.5 inches longer than the anatomy, because of that divergence of the central ray. Consider the anode heel effect. Because you've got these patients with these great big forearms, consider putting the thickest portion of the forearm under the cathode end of the x-ray tube. I used to say, people with Popeye forearms, and a few years ago I realized that maybe y'all don't know who Popeye is. He's a cartoon character from way back in the day. He was a sailor, and he had great big forearms, so Popeye forearms. So on the AP, we shoot the AP to prevent the crossing of the radius over the ulna. If you put your hand in a prone position with your elbow straightened out on the desk in front of you, then you hold it like that, and then you rotate from your hand being supinated to pronated. Then what you should see is your elbow doesn't change that much. Your elbow is probably going to oblique a little bit, but it's not going to change in orientation nearly as much as your wrist does. And that is because the rotation occurs in the elbow, so that the radius on the lateral side crosses over the ulna on the medial side. In the event that you have a patient that you're pretty sure has a fracture, if they've got an obvious deformation of the anatomy, put the joint that's closest to the fracture in the proper position. So if it looks like the patient has a proximal forearm fracture, try to get it supinated the best you can, and try to get the arm, the elbow, in a true AP projection, even if you can't get the hand supinated. On the distal end, try to get the hand supinated. So make sure that whenever you pick it up, you support it proximal and distal. Central ray is just going to be to the midshaft. Radius and ulna should be parallel. Wrist should be AP, providing your patient doesn't have a fracture. Your proximal humerus should be really in an AP type anatomical position. Elbow should be completely extended, and your humeral condyle should be parallel to the image receptor. So what you're going to do to detect rotation is you're going to look at both the proximal and distal end separately. So the radial tuberosity should have about 1/2 to 1/4 inch superimposition. So what we're looking at here is this thing right here. All right, so you got radial head. Radial head's flat. We see a portion of the radial head superimposed by the ulna, but the radial tuberosity is this thing, and that's really where your rotation occurs. You've got ligamentous attachment there that turns the radius around the ulna, so that you get a pivot right there, and this whole thing just twists around, right? So you should have that superimposition right there. On the distal end, you're going to have slight superimposition here as well. So if you have internal rotation versus external rotation, it's kind of going forward into elbows. I hit pause and don't know where I left off, so I'm going to go back to this slide right here. So AP forearm, supinated hand, it prevents crossing of the radius over the ulna. If the patient has an obvious deformity and we're looking at a probable fracture or an obvious fracture, then we're going to place the joint that's closest to the fracture in as close to the proper position as possible. So if it looks like they got a proximal forearm fracture, get the elbow in true AP. If it looks like they've got a distal forearm fracture, try to get the distal forearm and the wrist in the AP projection. So anytime they've got a fracture, especially a mid-shaft fracture, make sure that you support proximal and distal. Central ray is going to be right to the center of the anatomy. The radius and ulna should be fairly well parallel. The wrist should be AP. Proximal humerus should be AP. The elbow should be extended, and the humeral condyle should be parallel to the image receptor. So how we detect rotation is by looking at the radial tuberosity and its superimposition over the ulna. If we have any kind of rotation, then what we're going to have is an increase or decrease in that superimposition. And I'm going to go down to the obliques of the elbow to show you what I'm talking about. Actually, this is AP of the elbow. We've got a little bit of superimposition radial head. We've got a little bit of superimposition there. But in external oblique, what we're going to see is a separation between the radial tuberosity and the ulna so that you can actually see through there. If we have medial rotation, then this is extreme. This is truly an oblique of the elbow, so this would be with the hand pronated. But if you were to internally rotate, which is more common of the positioning errors, you position the patient truly for an AP of the forearm, AP of the elbow, and you disappear behind the control panel and the patient starts to relax, they're naturally going to internally rotate. And what that's going to give you is an increase in superimposition on the proximal, especially the radial head and the radial tuberosity. So what we're going to be looking for is lateral is the fat pads. You've got several of them that you're going to be looking for. Fat pads should be present, but they shouldn't be optimum because of the divergence of the central ray. You're going to have some distortion of the fat pads. But on the wrist end, you're going to see the pronator fat pad. You're also going to see the supinator fat pad. You may see the anterior fat pad on the distal humerus. You may see the posterior fat pad on the distal humerus. Supinator fat pad is anterior to the radial head. So they're going to look like that. You got supinator, you got anterior, you got posterior fat pad, which is going to be tucked inside of the olecranon fossa on the backside of the humerus, and you got pronator fat pad right there. So the evaluation is going to be just like evaluation of either the wrist or the forearm or the elbow, as we'll talk about later on, without it being ideal. Again, because of the divergence of the central ray, everything's going to be a little bit distorted on both proximal and distal end. But the lateral on the proximal end, what you're going to be looking for, I'm going to go to a lateral elbow, is the condyles, the humeral condyles should be fairly well round, like so. So if you've truly got a good elbow, I understand I'm taking a little bit of a deviation here, but if you've got a good elbow, then those two condyles are going to be perfectly superimposed like that. So you got this one almost perfectly round density. You're not going to see that on a lateral of the forearm because, again, of this divergent central ray. But the positioning for the lateral elbow and lateral of the forearm should be really the same. Central ray location, collimation are fundamentally the only differences. So what I want you to hang on to for this is, let's say this is representative of your distal forearm, or your distal humerus, rather. So what you've got here is you've got your two condyles, and when they're perfectly superimposed, again, my camera is backwards, so every time I move that way, it looks like it's moving towards, one direction, but to me it's going the opposite direction of what I'm showing. So if they're perfectly superimposed, you see this nice round density, right? So it's perfectly superimposed. So if you've got anything that causes that superimposition to be changed, in other words, you got a big fat forearm and a small wrist, so that you get these great big fat Popeye forearms, and a wrist is down like that, and your elbow is up, then what that's going to do is it's going to take those condyles, instead of being perpendicular to the image receptor, it's just going to tilt them so that you got two condyles, right? You got the capitulum, you got the trochlea, the radius, the radial side articulates with the capitulum, right? What we're talking about is the humerus and the relationship of those condyles on the humerus, okay? So if we've got the shoulder that is higher than the elbow, then what we're going to have is the capitulum on top is going to be projected distal to, because it's in relationship to the humerus, distal to the trochlea. If we've got a situation where we've got big old fat Popeye forearms and skinny wrist, then it's going to be anterior to, again, because we're considering the anatomy of the humerus and not the forearm itself, but it's going to be anterior. The capitulum will be anterior. So if we've got a situation where we've elevated too much, then the capitulum is going to be proximal. And if we've got a situation where we've got elevation of the hand, then the capitulum is going to be posterior. Most difficult thing, most complicated thing that we're going to talk about, or we have talked about today, and probably the most complicated thing in the upper extremity, is where will the capitulum be in relationship to the trochlea on both your lateral forearm and your lateral elbow, but especially your lateral elbow, because on the forearm they're never going to be perfectly superimposed.